Yep. So, hello everyone. This is Dr. Vivek Goel, your nephrology faculty at Doc Tutorials. And here we are at the YouTube live session to discuss with you the free module, which was the fourth module in the Elite Test Series 2023. So, at the outset, we have got a wonderful response from students all across for the Elite Test Series because, we've always had a very high yield of questions from our Elite Test Series in the final exam because we prepare the papers in such a way that it actually simulates the exact exam with a good mix of both factual and conceptual and clinical vignette based questions. So there were 25 questions in this free test series, which mainly hailed from the inherited, the renovascular, and the glomerular diseases. So I have chosen one of the most important topics for you as a free session for you all at the YouTube channel. So by now, I think most of you have already become live. And if you have any doubt, you can absolutely ask me then and there, and I will be most happy to clear your doubts. So the very first question was TRPC6 cation channel mutation produces what disease? Is it FSGS? Is it minimal chain disease? Is it lupus or is it IgA nephropathy? This should be a fairly simple question for you. We know that TRPC6 is one of the causes, mutation is one of the causes of an inherited form of FSGS. It is a genetic form of FSGS, which is basically inherited in the form of autosomal dominant inheritance. Now, I would also like to discuss a few allied MCQs so that your life becomes easy. I have taken this table right from your Fihali 6th edition, and you know that your inherited or congenital FSGS, your basically inherited FSGS could be autosomal recessive or could be autosomal dominant. Now, autosomal dominant are only few, which are around these 8 genes that cause autosomal dominant FSGS. Rest all are autosomal recessive. So for MCQ purpose, if you remember the names of these 8, the life will be very, very easy. So can we do that? Yes. How can we, sir? Please have a look. Please have a look. Their name, you can, I remember them with a very, very lame mnemonic. That is A, W, I, L, M. So it is A, triple A. It's a season of triple R now, but it is triple A, Wilms tumor. T for tumor. So it is A cube Wilms tumor. What are the AAA? It is actinin alpha 4. It is aniline. It is ERGAP24 AAA. It is aniline, actinin, ERGAP24. W for Wilms tumor 1. I for inverted formin 2. L for LMX1B. Then you have the M for MYH9 or the myosin heavy chain 9. WILM, Wilm, T for TRPC6, which is the question. Is it okay? Now, another set of questions is MYH9 mutation causes Fechner syndrome. This is an old question. Okay. Now, apart from these 8 mutations, all the rest are autosomal recessive. So if I ask you, which is the most common inherited FSGS, in childhood? Which is the most common inherited cause of FSGS that occurs in adulthood? Sir, the two answers are very, very important. In childhood, it is the NPHS2 mutation, which causes a mutation of the podosin, and in adulthood, it is the inverted formin 2. It is the INF2. So 2 is a common factor, if that helps you remember anything. Am I clear? Now, INF2 mutation causes a nephrotic syndrome which is known as FSGS type 5. So if there is something known as type 5, there must also be something known as 1, 2, 3, 4, but that is not that important. The TRPC6 one is known as FSGS type 2. So these are the some of the very, very important points I would reiterate for you. Number one, these 8 mutations are AD, rest are AR. What are AD? A cube VT. So it is aniline, actinin, ERGAP24. Then you have the Wilms tumor 1, inverted formin 2, LMX1B, MYH9, and TRPC6. Out of these, the most common in childhood is NPHS2, most common in adulthood is inverted formin 2. And type 2 FSGS is caused by TRPC6, which was the question. I hope this is clear to you. Now, moving on to the next question, which was a sitter, but trust me, sometimes these simple questions really confuse you. Normal 24-hour albumin excretion in an adult person is, it is 8 to 10 milligrams per day. You know that in an adult, a person excretes up to less than 150 milligrams of protein per day, out of which 50%, that is 75 grams, is your TAM horsefall protein or uromodulin. Around 10 grams is your albumin. And the rest are your beta-2 microglobulin, your urokinase, your immunoglobulins. I hope I am clear. Now, this table, though appears the most simple, but it is very, very important. Please understand that your albumin normally is excreted at a rate of 8 to 10 milligram per day. If it is excreted between 30 to 300 mg per day, that is known as microalbuminuria. If it is more than 300, that is known as macroalbuminuria. But now these terms are replaced by moderately increased albuminuria and severely increased albuminuria. Am I clear? The most common cause of infectious disease associated glomerulonephritis worldwide. So this is basically IRGN. Now this again, this question, this line has been taken from the Harrison's 21st edition directly. The Harrison reads that you have the, except for SAB in the Western Hemisphere, malaria, schistosomiasis are the most common cause of IRGN, followed by HIV in the world. Am I clear? Throughout the world, it is the malaria, schistosomiasis, followed by the HIV. So this question is directly taken from your Harrison's. Now, which of the stains is best used for visualizing glomerular basement membrane? Now, these practical questions, which are allied with other basic subjects like pathology, are very often asked. Now, you have to understand that there are few stains which are very, very important. Number one is HNE. Number two is SPAS. Number three is silver, which is the Jones methenamine silver. Then you have the Mason's trichrome. Then you have the Congo red. So what do you see with each one of them? Now, HNE basically helps you to assess the cellularity and basic structure. So that's a very, very basic stain. Nothing, it doesn't tell you anything specific about anything. PAS tells you, PAS basically stains what? It stains the carbohydrate moiety in the membranes of the glomerulus and the tubules. So PAS will stain both the GBM and the TBM equally. And that is one of the ways to differentiate between HNE and PAS. If you see the TBM very brightly stained, that is PAS and not HNE. That is the way to differentiate. Next is the silver, which actually is the best stain for the glomerular basement membrane. It enhances the glomerular basement membrane. Mason's trichome can be used for multiple purposes, but basically it is dark or brighter in areas of collagen deposition. And that is why wherever there is glomerulosclerosis or interstitial fibrosis, Mason's trichome will come into play. And last but not the least, Congo red is the most easy stain to know. You already know by now. It is the stain for your amyloidosis. Yeah. So these are the stains. So the question was, which stains the GBM the best? Answer is the methenamine silver, which is a Jones stain. So nephritis associated plasmin receptor is associated with which glomerular disease? Is it IgA nephropathy? Is it C3GN? Is it lupus? Or it is post-streptococcal glomerulonephritis? And the answer is post-streptococcal glomerulonephritis. Please understand that PSGN is an immune complex mediated glomerulonephritis. It is an immune complex mediated glomerulonephritis, which involves what? It involves certain putative streptococcal antigens, circulating immune complexes, and activation of the complement in association with cell-mediated injury. So these are the numerous mechanisms. Many antigens have been proposed. The candidates, what are the antigens that cause these, these mechanisms? They are the nephritogen, from the nephritogen streptococci, the antigens are, sorry, yeah. So the culprit antigens are cationic cystinase proteinase, that is a cystinase proteinase known as the SPEB, which is the streptococcal pyrogenic exotoxin B. You have the nephritis associated plasmin receptor, which is the NAPLR, which is that being talked about. So these are the important two antigens, which is the SPEB and the SPEB and the NAPLR. Streptococcal pyrogenic exotoxin B and the nephritis associated plasmin receptor. These are the antigens that actually cause the cross immunity, immune crosstalk, and cause the glomerular injury. Now, with this, what are the pathogenetic mechanisms in different IRGN? So as we were reading that in PSGN, numerous mechanisms have been described. Again, this table has been taken from Fihali. Numerous mechanisms have been described, and so it could either have a circulating immune complex. So the antigen antibody complex could be circulating. Again, it will be against the SPEB and the NAPLR. It could be an in situ immune complex. So there is not a circulating immune complex, but inside the kidney, there is an in situ immune complex formation, which is basically antibody binds to the SPEB in the subepithelial deposits. And last but not the least, nephritogenic antigen deposition. So there is an antigen deposition with complement activation, which is basically the NAPLR and the plasmin activity. For staph, again, it is a super antigen binding to the APCs, which is activating the polyclonal B cells and the T cells and activating the immunoglobulin deposition. Some viruses cause direct injury to the kidney, which is the hepatitis B, the parvovirus, and the HIV. And hep C can, of course, cause cryoglobulin formation and thus invade the kidney. So these are the numerous mechanisms of causing IRGN. The next question would be the sitter, diffuse nephritis Hello. Did it get disconnected? Yeah, I can start now. I hope I'm audible. There was some technical glitch, I think that occurred. All right. Chalo. So the next question, I'm very sorry for the technical glitch. Diffuse nephritis corresponds to which class of lupus nephritis? So is it class 1? Is it class 2? Is it class 3? Is it class 4? Or is it class 5? We know that the different classes of lupus nephritis as given by the ISN-RPS classification are number 1, minimal mesangial, number 2, mesangial proliferative, number 3, focal proliferative, number 4, diffuse proliferative, number 5 is membranous, and number 6 is sclerotic nephritis, where more than 90% of the glomeruli are sclerosed. So the answer to this will be your class 4 lupus nephritis, which is the most common class also. And this is the class where you most often get the wire loop lesions. And why do you get wire loop lesions? Due to the subendothelial deposits. Now, Oxford classification and MESC score are used for what? This is used for a IgA nephropathy. Please understand, this is a score for the pathologic grading. But this score, it does not tell you. It does not tell you about therapeutic decisions. Sir, what do you mean by that? What I mean is, based on MESC, you will not be able to judge whether or not to start the patient on immunosuppression, whether or not to give the patient steroid. What is MESC first? Let's have a look. So MESC stands for mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, tubulointerstitial fibrosis, and C for crescents. Now, how are they graded? Now, please understand, in every glom, we count the mesangial cells per unit area, and we give a score of 0 to 3. Now, you give a score of 0 if there are less than 4 mesangial cells per unit area. If there are 1, if you give a score of 1 if there are 4 to 5 mesangial cells per unit area. If there are 6 to 7, you give a score of 2. And if there are more than 7, you give a score of 3. Like that, you score all the glomeruli and divide by the number of glomeruli to get a average to get a score, which is basically the average M score. And now, if the score is more than 0.5, that is M1. If the score is less than 0.5, that is M0. For endocapillary hypercellularity, if there is hypercellularity present within the capillary lumen, which results in narrowing of the lumen, that is E1 or it is E0. For segmental glomerulosclerosis, if any part of the glom tuft is sclerosed, it is S1. If it is not, it is S0. If there is a tubulointerstitial fibrosis, which involves up to 25% of the area, that is T0, 26 to 50% is T1, and more than 50% is T2. And crescents, if cellular or fibrocellular crescents are present in even one glomeruli, that is C1. If they are present in at least 25% of the glomeruli, that is C2, or it is, if there are none, then there is C0. So ultimately, you have an M0 or 1, you have an E0 or 1, you have an S0 or 1, you have a T0, 1, 2, and C0, 1, 2. This is the final pathologic report of a IgA nephropathy patient. But this is only to do what? For a pathologic grading. This will not help you in making therapeutic decisions. All right. And also there are quite a few criticisms of this scoring, but this is what is available right now. What percentage of idiopathic membranous nephropathy have anti-PLA2R positivity? The answer is 70%. So idiopathic or primary membranous nephropathy have anti-phospholipase A2 receptor antibody in around 70% patients. So we can still have a 30% of anti-PLA2R antibody at 30% of primary membranous nephropathy patients which have a negative anti-PLA2R antibody. So what if I get an anti-PLA2R antibody? Number one, it shows that it is a primary membranous. Number two, it removes the need for kidney biopsy. I can diagnose a membranous patient without doing a kidney biopsy. This is really awesome. Next, it helps me to prognosticate. Higher the anti-PLA2R titer, worse is the grading of membranous nephropathy, because membranous nephropathy can be graded into mild, moderate, severe, and very severe based on proteinuria and anti-PLA2R titers. Next but not the least, it helps me making treatment decisions. And it helps me to judge the response to treatment. Why is that so? Because anti-PLA2R titers, they are the first one to fall after treatment, even before resolution of proteinuria. Now, this is a beautiful diagram, a beautiful schematic figure that will clear all your concepts. Now, please understand, in the initial phase of the disease, it is the tissue which is positive for PLA2R, but you do not have a serology positive. So basically, in the initial part of the disease, the serum anti-PLA2R is negative. The serum will be negative, but biopsy will be positive for an IHC marker for a positive staining of anti-PLA2R. Then what happens is, then you have what is known as your proteinuria, which starts. So this red is the proteinuria or the clinical disease. And after proteinuria sets in, the clinical disease sets in, you have your serum anti-PLA2R antibody also. So please understand that now both your tissue and serology will be positive. After treatment, supposingly you have treated the patient, or the patient was a mild one and there has been a spontaneous remission, which is quite in a decent up to 30% patients of membranous nephropathy, what happens? It is the anti-plateau serum titer which falls first. It is the anti-plateau serum titer which falls first, followed by the proteinuria. So actually, again, you know that proteinuria actually falls late, and plateau serum titer, it precedes proteinuria resolution, but still tissue will be positive. So in both the extremes, tissue positive, serology negative. Which of the following statements is false? 40% patients of approximately 40% patients of diabetes develop nephropathy. This is absolutely true. Within 1 to 2 years of onset, morphological changes start appearing in the kidney. Only 60% patients of type 2 DM will have diabetic retinopathy, and microalbuminuria appears 15 to 20 years after the onset of diabetes. Now, please understand, it is absolutely true that within 1 to 2 years only, the changes start appearing, and the earliest changes, GBM thickening, which can be seen in an electron microscopy. Only 60% patients of type 2 DM will have retinopathy, and in type 1, it is more than 90%. But microalbuminuria appears approximately 5 years after the onset of diabetes. Okay? Now, DNA JB9 is a marker of amyloidosis. What is DNA JB9? DNA JB9 is basically a heat shock protein, and it is an immunohistochemical marker with a specificity and sensitivity of more than 95% used for fibrillary glomerulonephritis. So these are basically non-amyloid fibrillary gene. So this is that fibril which is not an amyloid, mind you. Okay. This answer is fibrillary glomerulopathy. Most common cause of renovascular hypertension in a 55-year-old male. It is not Takayasu, it is not FMD, it is atherosclerosis. And if the question was in a 35-year-old female, then the answer would have been FMD. But here it is atherosclerosis, atherosclerotic renal artery stenosis. Now, again, a clinical question, very important. A renal artery stenosis of greater than 60% corresponds to a peak systolic velocity of what? Now, the peak systolic velocity will be higher in a patient who has a significant renal artery stenosis. So higher than what? Higher than 200 centimeter per second. Many books write even 220 centimeter per second. Am I clear? And there is another ratio which is known as renal aortic ratio of more than 3.5. The usual peak systolic velocity is around 150 centimeters per second. But here it will be more than 200 if the stenosis is significant. Now, ratio of length to left renal vein to right renal vein. You know that the left renal vein is 3 times longer than the right renal vein. It is 3:1. And that is the reason that you choose the left kidney for donor nephrectomy. Very important applied anatomy, because you get ample length of the left renal vein to clip between 2 clamps and then to ligate and then clip it so that it actually enables you to secure a good hemostasis with the recipient. Now, not a feature of cholesterol embolism. Now, cholesterol embolism is also known as atheroembolism. Now, what is not a feature? Now, what happens? For atheroembolism, what do you need? You need an atherosclerosis and an embolism. So the patient must be having a pre-existing atherosclerotic vascular disease. And for embolism, the patient must have undergone an invasive cardiovascular procedure like a coronary angiography, like an angioplasty, like say the patient was started on say a blood thinner, maybe. Okay. So, and any intervention that could have enabled to dislodge the atheromatous plaque and cause an embolism. So, what is not a feature? If that embolism goes into the small vessels of the skin, that will cause livedo reticularis. If it goes into the small vessels of the retina, that will cause a Hollenhorst plaque. There, if now those, those cholesterols get embolized to the kidney also, and when having, they dissolve when the tissue is fixed. So you see nothing but empty clefts because cholesterol dissolves in the in the fixatives, and that is why that is known as a cholesterol cleft. You see empty spaces. But last but not the least, due to the activation of the alternate complement pathway, you get a low C3. You never get a normal complement level. So the answer is D. D is not a feature of cholesterol embolism. So hypocomplementemia is seen in around 25 to 70% of patients along with elevated LDH, along with creatinine kinase elevation. There could also be peripheral eosinophilia in around 50% patients. Now, that brings me to again a very, very important table about the complementemia in glomerular disease. This has been asked time and again. I have also told you innumerable times about this table. There is a classic complement pathway which leads to, low C3, low C4, low CH50, which classically occurs in the lupus nephritis. There is only a alternate complement pathway which actually causes what? There is only a low C3 and a normal C4 which occurs in your post-streptococcal glomerulonephritis, your hemolytic uremic syndrome, your dense deposit disease, and another disease which is a non-glomerular disease but atheroembolism, and other reduced complement synthesis can occur in other diseases. So if there is both C3, C4 low, you must think of what? You must think of lupus nephritis and some IRGN also. If there is an isolated C4 low, only classic complement activation, you must think of cryoglobulinemia. Now, one clip, two kidney hypertension. So, let me first make you just understand this concept and then we will attempt that question. So there are two models of renal artery stenosis. One is a unilateral renal artery stenosis where there are two kidney, one clip, and there is a bilateral renal artery stenosis where there is two kidney, two clip, or one kidney, one clip. It's all the same. Now, what happens here? If there is a unilateral renal artery stenosis in the kidney where there is renal artery stenosis, there is reduced renal perfusion. For that, there is a RAS activation and there is an angiotensin II dependent hypertension. In the contralateral kidney, due to increased renal perfusion, there is something known as pressure natriuresis. And that is the reason the volume does not build up in unilateral renal artery stenosis. The patient does not develop a flash pulmonary edema. Contrary to that, in bilateral renal artery stenosis or one stenosis in a solitary kidney, what happens? There is bilateral decreased renal perfusion. The RAS gets activated. But due to water and sodium being retained in the body, there is volume expansion and there is decrease in the angiotensin II due to volume expansion. So the basic funda of unilateral artery stenosis is activation in the RAS, and bilateral, there is buildup of volume. There is mainly volume expansion. So now the treatment of unilateral renal artery stenosis would be what? You have to give a RAS blocker. But in bilateral renal artery stenosis, the main treatment would be treat the volume, give diuretics, volume depletion. If not, the patient may even have to be dialyzed if the urine output is very low. But if you check for the plasma renin activity in your unilateral renal artery stenosis, it is elevated. In bilateral renal artery stenosis, your plasma renin activity is low. So now let's attempt the question. One clip, two kidney. So there is a unilateral renal artery stenosis associated with primary hypertension. No. Drug-induced hypertension? No. Renovascular hypertension? Of course, yes. So the answer is C. Very, very easy. What of the following statements is false about Alport syndrome? Hearing loss in AS is congenital. No, it starts in adolescence, so it is not congenital. Anterior lenticular is pathognomonic of Alport syndrome occurs about 15% of males with X-linked Alports. Yes, this is the correct answer. This is true. Macrohematuria in childhood, nephrotic syndrome, and the finding of diffuse GBM thinning by EM are risk factor for CKD in affected female. This is also true. So the answer, none of the above is of course not true or false. So the answer to the question is A. This is false. Now, urinary fat oval bodies with a Maltese cross configuration are found in which disease? So there is a disease known as Fabry's disease, where there is a deficiency of alpha galactosidase. Due to deficiency of alpha galactosidase, there is what? There is deposition of sphingolipids in the kidney and in the tissues, because this leads to not the, this is an inborn error of metabolism. So the metabolism of glycosphingolipids does not take place and they get deposited in the kidney and numerous tissues. And that is why these sphingolipids ultimately are excreted in the urine, and which cause lipiduria or sphingolipiduria, and which lead to your fat oval bodies which have a Maltese cross configuration and a polarizing microscope. So the answer is your Fabry's disease. Answer is Fabry's disease. Again, a very simple genetic question. LMX1B, I have already discussed. This also causes an AD type of FSGS. Associated with Alport syndrome, of course not. It is not the Alport syndrome. In Alport syndrome, you have the what? You have the collagen 4, which is mutated. Fabry's disease, of course, I've told you it's a mutation of the alpha galactosidase. Joubert syndrome, again, not. That is basically a nephronophthisis. It is the NPHP gene. But in Nail-Patella syndrome, it is the LMX1B mutation, where you have nail dystrophy, you have the absent patella, you have the absent iliac horns, and you have FSGS type of kidney disease. Now, renal cell carcinoma associated with von Hippel-Lindau or VHL gene, what are they? They are mostly clear cell type, but they are very, very robust because they are bilateral, they are multifocal, so they are really very advanced, which occurs with the VHL disease. Now, tuberous sclerosis 2 gene associated with tuberous sclerosis is located on which chromosome? Now, you already know that tuberous sclerosis is of type 1, is of type 2. TSC1 is on the 9q and the TSC2 is on the 16p. So TSC2 is associated with which chromosome? It is the 16p. I hope this is clear. Now, why this is also important to you is because the TSC2 gene is on the 16p. Another very important gene is on the 16p, which is the PKD1 or the polycystic kidney disease 1 gene. Sometimes there is a continuous gene deletion of both the genes. And if there is so PKD1 and PKD2, PKD1 is also on 16p. If by chance both of these genes on the same chromosome, on the same limb of the 16 chromosome, gets deleted, that can lead to something which is known as continuous gene deletion syndrome, which can lead to very early onset ADPKD. We know that ADPKD usually occurs in the adulthood, starts from the third to fourth decade. But if this occurs, it can start as early as in the first decade. This is very, very important MCQ. Continuous gene deletion syndrome. Now, oculomotor apraxia is seen in the Cogan syndrome, which is basically a feature of the nephronophthisis, NPHP, or nephronophthisis. So, because, there are extra renal abnormalities around 20% patients of nephronophthisis. That can be what? There can be there can be retinitis pigmentosa, which is known as your senior Loken syndrome. There can be oculomotor apraxia, which is known as a Cogan syndrome. There can be a flat electroretinogram, which is known as Leber amaurosis. And there can be cerebellar vermis hypoplasia, which is known as Joubert syndrome. So these are basically extra renal abnormalities of nephronophthisis. These are mainly factual questions. What about the following statement about ADPKD and intracranial aneurysms is true? All ADPKD should be screened for intracranial aneurysms? Absolutely wrong. Most rupture? Absolutely wrong. The risk for rupture depends on the size and location. This is absolutely true. An MR angiography is contraindicated in advanced CKD because it requires gadolinium. This is absolutely wrong because it is the contrast MR that requires gadolinium. Your MR angio does not require your gadolinium. Now, please understand that actually it is the location, it is the size. So, ranging from less than 0.5% for smaller than 5 mm to 4% for larger than 10 mm. And it is the posterior circulation aneurysms that rupture the most. So, all patients should not be screened. Then the $1 million question is, who should be screened? Who should be screened? Number one, who have a family history of rupture. Number two, who have clinical features like headache. Number three, who is going to join a high-risk occupation, like a pilot, like a deep sea driver. So he will be at a high risk of future rupture. If a patient is going to be put on chronic anticoagulation, or if a patient is very anxious about something, then get it tested. No harm. Most common valvular abnormality in ADPKD is the mitral valve prolapse, and where you get the systolic click, which occurs in around 25% patients. Most common type of renal stone is none other than not calcium oxalate, which is the otherwise most common renal stone. But in ADPKD, it is the uric acid stone. And what contributes to uric acid stone? Because of decreased urinary citrate, because of urinary stasis of ADPKD, the cysts get distorted and there is urinary stasis. Also, there is proneness to infection. So all these causes lead to uric acid stone, which is the most common stone in around. ADPKD can have a renal stone on 20 to 25% patients. Which of the following antibiotic is an antibiotic of choice for treating cyst infection? The answer is not please understand that to treat a cyst infection, you require an antibiotic which must be able to diffuse from the tubules into the cyst. So it must be lipid soluble. It does not require polar antibiotics like aminoglycoside because they will not penetrate the cyst. So you require lipid soluble antibiotics. And which are those antibiotics? You have the trimethoprim sulfamethoxazole and the fluoroquinolones, which are the drug of choice and not the aminoglycoside. So with that, we have come to the end of this free session on the YouTube, where I have tried to discuss these 25 questions. Also, I've added a lot of, supplementary information here and there. I'm most welcome to listening to doubts, if any. Otherwise, you could easily reach out to me. My email ID is drvivekgoel89@gmail.com. My phone number is 9830940818. This is also my WhatsApp number. So please WhatsApp me, please mail me, or you can even message to me on the social media. I'm available by the very same name on Facebook and on Instagram as well. So I hope to listening from you. I hope to hearing from you doubts, and all the very best for the upcoming exams. Thank you.